We still have a lot of people joining.
All right. How about a Barry? Is she in yet?
Not yet.
Hey, Michelle,
Yes, sir.
are you there?
I
Are you looking for me to take the minutes as three separate votes, or can I take them all as not a consent calendar, but all as one?
Yeah, you can do it as all as one. You just need to identify all three of them.
Right. Okay. Thank you.
And Van, we're sending over the instructions for closing the session because we have two bases. Christina, you should have that now.
Okay, thank you.
It's the
Did you
standard
send,
form. Yeah,
you
it
sent
just,
it?
yeah, I just
Okay.
cited the parts of the Health Journal article that authorize closing the session for the proprietary material.
Okay, Van, Dr. Aniqua goes here. I'm letting her in.
And Steven's on, right?
I have not seen Dr. Rocco yet, no.
He mentioned that he was postponing his vacation for a day in order to be here.
Well, you know what? We have a quorum with Barry, Joe, Jerry, and myself. So, and I've got 2:03. So we're going to go ahead and get started. You did hit the record button, right, Christina?
Yes, we are recording.
Okay. Well, thank you all very much for joining our Maryland Prescription Drug Affordability Board meeting of May 19. Quorum has been established, so the chair calls the meeting to order. And the first order of business is approval of the meeting minutes that were submitted to the board members. We have 3 sets of minutes for approval. We'll approve them all at once if possible. We have March 24 regular meeting. We have March 24 of 2025 closed meeting minutes. And we have corrected January 27, 25 minutes. I think everyone should have those, so I will entertain a motion for approval if someone so desires.
So moved. This is Jerry.
Jerry, approval. Joe, second.
Second, this is Joe.
Joe, second. Any comments or discussion? If not, hearing none, all those in favor, aye.
Aye.
Opposed? Thank you. Approved as submitted. Okay, our item 3 is the opportunity for public comment. Christina?
Yes, we received 7 written comments. These comments were shared with the board and posted to the website. We received 1 comment after the deadline that will be posted on the website and shared with the board in accordance with the regulations. We have 2 requests for oral public comment today. The oral public commenters will have 1 minute and 30 seconds to speak. Please state your name, the organization, agency, employer, or other entity with which you are affiliated, if any, or whether you are a consumer, and the agenda item that you would like to address, and then you can start your comment. So I'm going to be calling on Denise Gilmore first. Denise, if you would like to introduce yourself, I'll get the timer set up. Miss Gilmore?
Yeah, hi, can you hear me?
Yes.
Perfect. Good afternoon. My name is Denise Gilmore, and I am here on behalf of AFSCME Maryland Council 3. Good afternoon, Chair Mitchell, members of the Prescription Drug Affordability Board, and staff. AFSCME Council 3, I'm here to talk about the cost review. AFSCME Council 3 represents 50,000 public sector employees across the state. And since 1970, we fought for the rights of our members on issues surrounding fair wages, working conditions, healthcare coverage, including prescription drug affordability. The skyrocketing costs of prescription drugs not only threatens the health and financial well-being of our members, but it puts considerable strain on the state and local government budgets and our healthcare system as well. We are pleased to see the progress that the Prescription Drug Affordability Board has made to date, particularly with the inclusion of anti-diabetics as initial drugs chosen for consideration. Anti-diabetics represent the single biggest cost for the state employee health plan, with net spending increasing over 100% between 2020 and 2024, from 14.5 million to 29.3 million. The runaway cost of prescription drugs drive our premiums upwards and threaten to force patients to shoulder the higher out-of-pocket responsibilities. AFSCME is proud to support the Prescription Drug Affordability Board in its current work, and we are eager to see the board enact the first upper payment limits for state and local governments for Jardiance and for Zyga. We urge the board to act swiftly in this decision-making process so that our state can begin to see a real relief from skyrocketing cost of prescription drugs. Thank you very much.
Thank you. Okay, next we have Erica Miller. Ms. Miller, if you would like to state your name, the organization, agency, or entity in which you're affiliated with, and then the agenda item you would like to address, and then I can start the clock.
Yes, good afternoon, everyone. I'm Erica Miller. I'm here with Healthcare for All. The item that I'm speaking to is the cost review study. My name is Erica Miller. I am a Baltimore City resident, and I work in data management, and I also run a nonprofit organization. And the prescription drug affordability is something that deeply impacts my life. I am here today to thank you for your current work on the cost review process, and I urge you to act swiftly so that you can bring relief to Marylanders such as myself. Several years ago, as I was working to get a diagnosis for my son, I learned well into my adulthood that I have ADHD. It explains so many of my struggles over the years, and while I initially tried to convince myself that this was something I should overcome on my own, I finally agreed to try medication. The static noise and racing thoughts disappeared, and for the first time, I experienced what I like to call a quiet mind. From the start, Vyvanse was expensive, but I was fortunate enough to be able to afford the nearly $100 a month copay. That changed when I lost my health insurance. Suddenly, I was facing a bill over $600 at the pharmacy counter. Forced to stop taking my medication, I felt the immediate negative impacts, and performing my corporate job duties became much more difficult. I know the high cost of prescription drugs caused me to lose my job. It is my hope that you can first help our state and local governments with skyrocketing costs. And thanks to successful legislation this year, you can expand those benefits to Maryland residents struggling to afford their life-saving medication. And in 2023, the makers of Vyvanse made more than $3 billion in revenue. But thank you. I ran out of time. I apologize.
Thank you very much. That concludes the public comment for today.
Okay, thanks to both of the folks that had public comment. Next, we'll get a update on our budget and fee assessment from, I guess, who's doing that? Andy, you doing that?
Yeah, that'll be me. Yep.
Okay.
Thank you, Mr. Chair. So as we come to the end of the fiscal year, which ends on June 30th, we did want to provide a quick update to the board just on the status of the revenues as well as our expenditure so far compared to the appropriation. And then we can also provide an update on our special fund as well. Next slide. So first, we just wanted to go through our revenue source, which is our summary of the FY25 fee assessment. We currently have a $1,000 fee assessment on manufacturers, pharmacy benefit managers, carriers, and wholesale distributors. We have an exemption process for entities that receive an invoice but are not qualifying entities under our statute or regulations. So that process has been updated over the years, but we're kind of at steady state now. Next slide. Up to date this point, we've sent out 340 invoices. The original list, it's gone down year over year as we kind of identify the key, the folks that should be receiving the invoice. So far, we've received payments from 1,018 entities, though that number I think may have changed since these slides have been posted. And we've approved about 57 exemptions and denied 41 exemptions. And then that leaves us sending about 224 entities to the central collections unit. So these are entities that should be paying the invoice, but have received 3 notifications and have not paid the invoice yet. So I think the key takeaway here is that our annual appropriation is right in that range of about 1,247,000 or so. And based on the revenue that's come in, plus the amount that we expect to come in through our receivables that go to CCU, we think that our revenues are just about matching where our budget is for this year. So we think we're in good shape here. We recommend keeping the fee assessment the same for FY26. That process will start at the beginning of July and August. Around that time, we can also start coming to the board to discuss our FY27 budget that we'll submit for the budget process for next year. But for right now, it looks like our revenues are matching our appropriation. Next slide. Yep. So our two things to note: our appropriation is $1,247,411, and our cash revenues, you can see they're a little bit higher than the fee assessments received. That's because we continue to receive fee assessments from previous years, so that's accounted for FY25 revenues, and then also there may be interest payments from our special fund, which accounts for these kind of layover numbers. That's not just the even thousand. Next slide. And then just for the board's reference, we do have a healthy special fund that can account for any if we aren't able to match our revenues to our expenditures. But we do plan to have that our revenues match our budget each year, kind of moving forward. So with that, I'm happy to answer any questions from the board or address any comments you have before we close out this year.
So Andy, this is Jerry. So we have new authority starting next year. And I think we'll probably need additional staff as a result of that additional authority. I know, so you're going to plan in the future to talk to us about it, but I do think we need probably 2 additional analysts coming on board in the next year or 2 in order to handle that additional responsibilities.
Great. Yeah, we appreciate that. In the fiscal note for that bill that passed, the expansion bill, they did account for costs associated with additional pins. So I think that's something we'll certainly work through, though that doesn't mean we get any money for it. It still kind of comes out of our budget and our special fund. So I do think this is something we'll want to work through for the FY27 budget. So we can look at that for an upcoming meeting, but I appreciate the comment.
And, maybe we ought to consider keeping many of them at $1,000, but some places that have much more impact on the state to raise their assessments to a higher amount.
Okay. We can consider that in future meetings.
Yeah, 2 things. When we set this up, Jerry, first of all, I wouldn't recommend doing that. One of the things that we said to the legislature when we proposed the revenue stream, which of course wasn't in the original bill, they told us to do it, was that we would assess everyone equal across the board. So we didn't get into situations as we had done in the past with the donut hole and Care First and hitting different people for different amounts of money. So we tried to stay consistent with that. And I would recommend that we stay that. So if you're going to move the fee, you move the fee equally across the board. Picking and choosing sometimes is not always the best from a legislative standpoint. The second thing is, in regards to the bill that was just passed, the forget the money for a minute. The more important thing is pens, and pens are the personnel identification pen number for an employee. We had 0, as you know, with the bill, and we negotiated to get 5. And so we only have 5. So Andy's going to have to go to the governor and DBM and try to get them to put 2 or 3 or whatever the proposal needs to be into their budget, because they're the only ones, or they're the controller of the pens. And that's going to be the bigger issue, is whether you can get the pens assigned to us, and then the second part will be raising the fees to pay for the pens.
And that can be accounted for in the FY27 budget, so we will bring that before the board this fall.
Yeah, the only thing I'd like to say to the board members is that we, meaning the staff, including myself, have been lax, in my opinion, at collecting over the last 3 years. We've talked to staff about this. The collectibles, or what should have been turned over to collections the last 3 years, could have helped our budget to the tune of $500,000 or $600,000 possibly. And it has to be done on an annual basis. So I hope now that they're going to move forward and do this on an annual basis, and the folks that aren't paying, they either need to apply for an appeal process that's set up in there, and they either get the appeal to where they win and don't need to pay the $1,000, or they need to pay. So going forward, it's my hope that we do a better job with the collections and turning them over on time, because I don't think we would be as tight as we are with the current budget if we were collecting the ones that we felt owed us money.
Great, thank you, Mr. Chair. Yeah, and our plan is to have the file submitted to CCU by the end of year, or the end of the fiscal year. So that should be accounted for in the budget. All right, any other questions on the budget?
But so could we start the process of getting new pins now? This is not.
Let the chair speak. I'm also happy to respond.
Well, I think that was Joe.
Mm-hmm.
The governor's going to have to give us the pins. They have to identify them, put them in the budget, and then we've got to guarantee that we'll pay for them. So it's a process, and you may remember or may not remember, but you know, there has been a hiring freeze for what seems like the last 8 or 10 years, and under Hogan administration, they wanted to reduce from 63 or 64,000 originally, I think, when I went in, to 50,000 or under 50,000. I've lost track of it now, but I would imagine with the constraints of the budget last year, you know, pens are at a valuable point, and if somebody's not in it, the budget committees generally take them because that's savings, and these times they're hard to give out. So I think we're going to have to go to them and see if we can identify the exact type of positions that we want and what the cost is with that, with benefits, and then put a proposal together. Which is why it's tough to be passing bills when you have a budget situation the way that the state has it. So.
Yep. Dr. Levy, we can account for that in our budget, so that'll be part of our process for putting that budget together. Yep. All right, any other comments or questions? All right, I think that's all we have for this agenda item, Mr. Chair.
Okay, so I really don't have anything. We've got the next meeting down at the bottom of the minutes, so why don't we just move to
Oh,
item
and Mr.
7?
Chair, I do have some
Uh,
administrative updates.
Okay,
I do
I'm
have some
sorry, go ahead.
administrative updates.
Go
Yeah,
ahead.
yeah, no problem at all. Great. So just a couple things. We moved the administrative update and the chair's update because we do plan to go into closed session at the end of this meeting, but then also don't plan on there being any additional action after that. So did want to let folks know that if we go into closed session and you don't have time, you're welcome to drop off. That's why we moved the closed session to the end of the meeting. On a related note, just a quick update on the dossier timing for Farsiga and Jardiance. So up to this point, the board and staff have met all the requirements for posting the board materials and allowing the board to review the materials. However, we want to try to implement best practices where if we're going to be have the board taking action on any specific documents, we do want to allow for at least 15 days for the public to review and provide comments. To that note, we hope to post, we're going to use today to kind of go through the current version of the Farsiga dossier. We're kind of using that as our template. We'll take any comments or feedback that the board has on this version, and then we plan to post a version for public comment of both Farsiga and Jardiance, again, incorporating any feedback that we get from the board today, sometime within the next 2 weeks. So when that is posted for public comment, we'll post it on our cost review study page. We will note the timeline for submitting public comments, and then we'll also send a blast email out to our listserv. So anyone that wants to be a part of that process, please do join our listserv. So that, again, we're hoping for it to happen within the next week or so. I'll go into, again, just some of the details of the dossier process momentarily, but did just want to flag that for everyone. And then the next thing is we also have we've done the request for information for 4 out of the 6 drugs. Staff intends to start the request for information process for the last 2 drugs. Similar to the dossiers, we're going to post the announcement on the website, hopefully within the next week or 2. And then we will do direct outreach to key stakeholders that may have information. And then we will also send a blast notification out with the deadline and then how to submit anything related to the request for information for the last 2 drugs. 2 more quick updates. One, we have 2 scheduled meetings that I think the chair just mentioned. One, just going back to our April 28th Stakeholder Council meeting, the Stakeholder Council has been taking on kind of an educational series where they're doing a deep dive into specific issues. On the 28th, we had a guest speaker from 3-Axis Advisors, Dr. Ben Link, who walked us through the supply chain and the different pricing metrics related to the supply chain, and then some of the challenges to how those pricing metrics flow through. So I think that's supposed to be a reference that this public, the Stakeholder Council, and even the board can use as we work through some of these complicated issues that we see in drug pricing. We have an upcoming meeting on June 23rd, and we're looking at probably a similar format of a presentation on key topics that is meant to kind of inform the Stakeholder Council and the public. And then finally, our next scheduled board meeting, I think we'll go over this at the very end, is on July 28th. Final update is on staffing. So as folks may know, we have 2 open staff positions right now, which has been a big challenge for the team. We're very excited to hopefully get some new team members on board. The closing for our quantitative data analyst closed on Friday. So we hope to start that interview process shortly. And again, there's a huge need for this person. So we're trying to onboard them as soon as possible and hope to be able to introduce them in our next board meeting. We also have an administrative position that's open as well, and we're working actively to fill that position as well. So going back to the chair's point on the importance of PINs and being fully staffed, staff is working as hard as we can to get back to full strength. So happy to answer any questions that board members may have based on that update.
So Andy, one of the things we're trying to do is help the department get lower rates for state employees and for others. Do we still have a sense yet of when is their deadline for getting that information to them?
We don't. That's something we can talk about as part of the policy review process. So what we've proposed in the policy, well, as part of our upper payment limit action plan, is that for state and local government, if the board wanted to move forward with an upper payment limit, it would be done basically through a contractual method where we work to get supplemental rebates for the partners that we're working with from the state and local government. So to your point, it is going to be based on each of the contracts and kind of the timelines associated with their work. The way that we plan to address that is we are currently in the process of recruiting partners for this work. So it can be the state, it can be different counties, it can be different municipalities. And then for each one of them, we will be kind of working within their specific timeline. So we haven't gotten a specific timeline from the state employee health plan yet, but it's something that we'll be working with them on to address.
Yeah, I just think I don't want to miss a deadline by a few days if we can help it.
Great. Yeah, we appreciate the input. Great. Hearing no other discussion on or questions about our administrative update, I'll turn it over to the chair for your update, though I think you had gone through that.
Yeah, no, I'm fine in sake of time. Why don't you go ahead and start on number 7.
Great. So for the rest of the meeting, it's the intention, and Christine, I'm going to take the...
Yeah, I'm going to stop sharing, Andy.
Yeah. Replace current chair. I think I got it. I think this is the right one. So Christina, you can see...
Yeah, we need to go
Okay.
back to page 1.
Yeah. Okay. Yep. Okay. So I'm sharing my screen now. So we've posted materials on our website that is going to basically be everything that the board is allowed to consider for the cost review study process. So it's a series of documents that we're calling our dossier, and then we have some supporting exhibits. In the last meeting, we went through the first 3 sections of each element. As of now, we've posted what we think is kind of the final format of what we expect the dossier to look like. However, we do welcome any feedback from the board members as you've been able to review these documents to let us know if any particular documents or exhibits or elements have been helpful, or if you think that there's anything that you would like us to refine in the final version for you to consider. So there's 3 kind of well, I guess I'll just go through this. This is the dossier, what we call our dossier, that has kind of the raw analysis of all the different elements that the board is allowed to consider. The general format is we have 8 different sections, and then each section has factors that are mapped to your regulatory elements that you're allowed to consider. So we did the mapping of, what our regulations say, and then basically our response to those regulations. So you have a table of contents. Looks like there's some formatting challenges there. So the version that we'll be posting for public comment will address any of those formatting issues. But we have these larger sections, and then the number of factors within each one. So I'll go through sections 4 through 8, just kind of show you what's in this document. Please stop me at any point if there's anything you would like to see differently, or if you want to discuss anything that you see here. And then at the end of the document, you can also see the series of exhibits that the board is allowed to consider. So we have the Exhibit 1, which is an Excel document, which is our therapeutics alternative pricing list. So you'll remember that we have the board approved a series of NDCs that represent the therapeutic alternatives for these drugs. And then we have a number of different factors that we're allowed to consider. I'll pull up that as an example. It's a pretty unwieldy document, but this was the right format for as many NDCs as we were able to, as we were required to include in this. Here, so let me see if I can. The next exhibit is the description of the MCDB statistics. So this is going to be the different metrics for each of the different therapeutic alternatives, including and also for the reference drug that are based on our analysis of the APCD, which is ours is called Medical Claims Database. So that's another Excel document, again, a very large and unwieldy document just because of the sheer number of NDCs. So the board members will want to kind of go through and scan through to identify the key kind of elements and drugs that you're interested in looking at as you navigate that and look for them. On Exhibit 3, we've aggregated all of the different written comments that we received from a series of different comment periods that we've had. We have, for all drugs, there's a 60-day comment period after they're posted. And then we've done 2 separate requests for additional comments just to ensure that we were giving folks adequate opportunities to provide comments. So we've aggregated those into a single document. The next thing that we've included is a redacted document just for board, well, I guess, but it basically shows pricing history for different pricing metrics. If we had to redact the confidential proprietary numbers, but otherwise I think we did include the public facing one. So this is just to show pricing trends over time. And then the last exhibit is all of our RFI submissions. So these are non-public, trade secret, and confidential and proprietary, only available to board members that have been shared in a secure fashion after appropriate training. We will also go into closed session after we go through these documents to discuss anything of any of the confidential and proprietary information that the board needs to discuss. So that's the general layout of the different documents and basically the universe of things that the board is allowed to consider as you make your affordability determination. Again, the ultimate step will be for the board to review this information, and then as part of the cost review study, make your preliminary determination on if a drug has led to or will lead to an affordability challenge, which is high cost to the healthcare system or high out-of-pocket costs for patients. So just going through the general layout. So you've seen these documents, sections 1 through 3 were posted at the beginning. I think one quick note to update is we did add the authority and then also the methodology and the data sources that were used for each of these data. I don't think there are any major updates. I think they're primarily formatting updates on section 2, so I don't need to go through that again. Moving on to element 3. Same thing, no major changes, primarily formatting changes. So I don't think there are any substantive changes on this. So that was all that was posted within the last version. Go ahead, Michelle.
I was going to say, Dr. York, you should start with 3.3 because the last iteration only went through 3.2.
Great, thank you for capturing that. Since we only went through 3.2, starting with 3.3, we analyzed the market context of the prescription drug product, including the prescription drug product's life cycle management, patent management, regulatory exclusivities, and product hopping. In this, we provide a descriptive list of the different patent listings and some of the comparable drugs that have similar ingredients. So this again just kind of talks about the market dynamics of different therapeutic alternatives, and especially the ones that have the same active ingredient and share similar manufacturers. So we do encourage the board members to review that information in terms of the life cycle. So yep, and then we include the spending tables for different drugs that have the same active ingredient that align with the different patents that are listed above. Again, all of this is supplemented in Exhibit 3 and Exhibit 4, which are Exhibit 1 and 2, which are the pricing tables, and then also the MCDB statistics. So these are all of this information that you see in these tables is extracted from that document. In Exhibit 4, we go through the utilization of the drug product under review. And for each of the NDCs, we provide the gross spending amount and the number of patients by payer type, all, again, available within the MCDB. And then we also include the percentage of total gross spend. So you'll see the actual percentage of the spend compared to the total gross spend for each of these payer types. We do it for Farxiga, and then also, this is all for Farxiga. A number of these statistics are also available on the therapeutic alternatives based on reviewing the 2 tables. 4.2 is the element of the change in total gross spend and utilization for the prescription drug product between the 2 most recent available calendar years. We again just include the descriptive statistics in these tables. for each of the different payer types that are worth reviewing. Here's the Medicare. Moving on to 4.3, we look at the impact of the utilization of spending for the prescription drug product on public budgets and in comparison to the prescription drug product. In this, what we were looking for was how basically the comparison of this drug spend to specific state budgets. So as you can see, what we did up here with the full state and local government, and then also for Medicare, which is its own payer type, and then also Medicaid. We tried to break that down by additional payers. So for example, looking at different budgets for different state entities and state and local government entities. At this point, the data that's available was not uniform in a way that allowed for apples to apples comparisons or any meaningful conclusions. So for this iteration of the dossiers, I think we're going to basically state that based on the information that was available, we were not able to draw any conclusions from it. However, we're going to continue to work with different state and local government partners and other public budgets to identify standardized data, and then also think about other ways to look at it, how specific drugs impact specific specific budgets. So we do think this is still an important factor, but just based on the data that we had available, it was difficult to draw conclusions that the board could use. For section 5,
So Andy, if you could stop on 4 for a minute.
Yeah.
I applaud you for getting up to 2022, 2023. Could you just give me the cycle as to when 23, 24 will be available for us?
So this may be, I'm not sure if Zaid is on the line. He is he does some contract analytics with us. The general cycle is that the next round of data is available kind of in the fall of each year. So we're going to be getting the next tranche of data. And I guess that would make sense, about 2 years. So I think for 2023, that data will be available in the MCDB kind of in the fall range. So it's something we would picture to be for the board to use within the next cycle of cost review studies. So there is, I would say, probably a 2-year lag on this, which we understand the challenges with that. I think it's something we've discussed in depth before. And we do try to supplement it. So for example, the costs, the pricing metrics are up to date based on the different databases. It's really the claims utilization and claims data that has that lag. You're on mute now, sorry.
I'm sorry. The state doesn't have more current data. I understand, you know, MCBS and all that, but I just wondered if you know, the state might have more current data.
Yes, we can. So part of what we try to do in this dossier is just keep things uniform, so it is an apples to apples comparison. I think if you start to work through the policy review process, we can start to look at more specific data. I do know that, for example, the State Employee Health Plan publishes quarterly reports that may be available, and it's something that we can get access to, but it doesn't map directly onto these analyses, if that makes sense. It's almost like a sub-analysis that we'd want to do.
It does, but I mean, I would prefer to have the most current data, especially since we're really focused on state employees.
Yep.
And even if it's a separate section, I understand the apples to apples argument, but I do think having more current data, especially for people that we're really focused on, makes sense.
Great. Yes, that's a great point. So one, we will see what we can pull together before we publish the updated version of this dossier. So if it's something that's readily accessible, we can see if we can account for it in this iteration of the dossier. If not, you will be able to account for it kind of in any kind of policy or review work that you do. And again, it will allow for a more nuanced conversation. When the board is making their determination, it is for the state. So I know when we talk about specific policy options such as upper payment limits, that's for state and local government, but your analysis here is based on the full state and all the different payers. But noted. Dr. Inokwe?
Yeah, certainly want to echo Jerry's comment on the amount of work that has gone into this, and not even just about the cost and utilization data, but before that, incidence, prevalence, So on this particular section, and I appreciate the difficulties with assessing data and collecting it, there was reference to, I think it was in factor 4.3 there on page 42, right,
Yeah.
where you are right now, about data not being uniform. And there's a bit of text in there. I think this is a really important part to be clear on. What do we mean by lack of
Yeah.
uniformity? Because this is the first time we're going through this cost review. And to the extent we can understand some of these barriers and be clear about them, it'll allow us to be more, I think, informed going forward. We can see if there are themes with other cost reviews that come down. You know, which of the counties, what do you mean by some local governments aren't providing and then some are? I
Yeah.
just wanted a bit more detail on this lack of uniformity for the
Yeah. So when we look at table, let's see where it is. So when you look at, for example, the A version of each table that includes this state and local government employee, that includes all, I mean, this is a little bit general, there might be some nuance to this, but this includes all entities that are within the realm of what Dr. Anderson was talking about, the state and local government employees. So state, all counties, I think all municipalities. So when we are doing our analysis at the APCD, there is a flag that lets us do the analysis at that level. What we're still exploring is if you wanted to parse that out and say, here is, to your point, like a certain county and the numbers associated with that, we weren't able to parse that out in a way that we were able to use for this analysis. It's something we're still exploring and may be able to do in future iterations. So the way we tried to work around that was to then go to each county's budget and look at their line items. Sometimes it's broken down by basically looking at the drug or the health spend for state and local, or for the employees of that county. And what we were finding is that each budget that we looked at, they categorize the line items slightly different. So sometimes the prescription drug fits with an overall health spend. Sometimes they break it out. Sometimes it's medical, and then vision and dental and prescription all get lumped into one. So basically, it's just based on the reports that we had easy access to, or that are readily publicly available. There was no way to kind of do the mapping that we needed to do. So two things that we're continuing to do is one, try to actually use the APCD to parse out and see if we can get to the county and local government level. But then also we are working with, it is a number that exists in the world. You just actually have to go to the source to get it, in terms of like actually just going to each county and getting their line items and seeing how they break it out. But it's a more labor intensive exercise than we had anticipated. So it's just not something that we'll probably have in this round of cost reviews.
Yeah, and I think that's fine. I
Yeah.
absolutely feel like the way the approach has been taken is appropriate. I just wanted to clarify, I was not asking for specific county level information,
Yeah.
more so a more detailed characterization of what non-uniformity looks like, which you've already been in the weeds to
I see what you're
understand why
saying.
that's not happening. I think
Yeah.
that higher level characterization will help us with future cost reviews. So as I look at a table like this, is it the
Yeah.
case that we're requiring any aggregation to include all the counties? Or do we have a minimum to consider it
Yeah.
representative?
Yeah.
Are we saying all or nothing? And if it's all or nothing, what got left out? Just a bit more of that. And again, not changing how we're reporting, but in terms of providing context for the numbers.
Yeah. So this does include all state and local government employees. Where we were having trouble was get filtering below that. And we're exploring how to do that in the future. But I think you can safely assume that this is representative of the state and local government employees that fits within that. So that's but that's based again on all payer claims database analysis. Yeah. One other note for the board is that we also were exploring other types of analysis that we could do that could get at this question 4.3. Sorry. Getting at this issue of like the impact and utilization of spending on public budgets. It's so you can see the analysis that we did, which I would say is probably like the entry level analysis, just kind of taking the spend on a specific drug and dividing it by a denominator of some public budget. But as we were discussing this, and as it was, when we were talking through the regulation itself, it seemed like there could be kind of a more nuanced or sophisticated analysis there. So it may not be available for this round of cost reviews, but if that's something that the board has a more specific intention on a look there, we can certainly explore those in future studies. Kind of long-winded way of saying, if you have a better way to do this, we'll take advice on it.
Yeah. I mean, I think it's fine the way you've done it. It would be nice to have more detail, but I don't think it's critical at this time.
Yeah, I know when we were originally discussing the element when we were going through the development of the regulations, we had talked about trying to identify if certain drugs had disproportionate impacts, basically what this is stating, but you can also look at it in terms of like if certain increases have different disproportionate impacts, or if any changes in the public budget have a disproportionate impact. But it's a pretty sophisticated analysis that we weren't able to do on this information. But if there is something like a standard process or procedure there, where on terms of budget-based analyses, were something we would look forward in future versions.
Yeah, I would be more interested in, if a new drug entered the market and therefore one of the existing drugs lost a lot of market share or something like that. So I'm much more interested in what's happened in 24, 25 kind of things, or what could happen in 26, given, somebody lose patents or something like that. So I'm as opposed to the more detail of what does Montgomery County have versus Howard County? That's fine, but I don't think I need that level of detail, but more current information wherever possible.
Great. So the next section is pricing information and rebates. So there's a lot of elements around this. And we published all the publicly available information that we can. So obviously the board's looking at the wholesale acquisition cost, the average wholesale price, the national average drug acquisition cost, and the state average acquisition cost, and the average sales price, as well as the federal supply schedule. These two are proprietary elements, but the rest of them are public elements that we've tried to include. Again, just giving a shout out to the stakeholder council meeting that happened on April 28th. If you wanted to go do a deep dive on what any of these prices mean, that's all kind of available in there. Dr. Nokogar, is your hand still up?
Oh, yes. So this is to an earlier section. I didn't want to forget to say it.
Yeah.
Where we had, I think it was all the way back 16, 17, where we had incidence prevalence, I believe, information
Yeah.
for US and Maryland. The NHIS data, I didn't know why we're using that year versus more recent years that are available online
Let's see.
for the National Health Interview Survey.
Yeah, I will have to take this back to the team and see if we can update this based on more recent data.
Okay.
Yeah,
No
so
problem.
thank you for flagging this. This is certainly something we'll take a look at. So we'll see if we can update based on more recent data.
I think the most recently available is 24, if not.
Okay, great. Yeah, and if we are using an older version, we will tell you why we're using older data. Usually, again, it goes back to trying to do apples to apples comparison. So I'll double check with the team on what we used that year.
With respect to the SAAC, I am a little bit concerned about it. It is a survey, as it says here, done by a particular firm. My experience of working with this is that not everybody responds to the survey. And there's sort of systematic bias as to who responds to the survey. So, I think it's important to look at it, but I would caution people who use it that there are some biases in it, and it tends to overestimate the cost in many cases.
Good, thank you. Yeah, and I think we did go through that. To your point, it's a voluntary survey and it's a self-selecting group that choose to submit, and that's what that's on. Though, based on the presentation in April, it does sound like it's one of the better metrics in terms of acquisition cost, but it does have its weaknesses that you just mentioned. So based on that, we provide the different unit prices and then the per year prices for WAC and AWP. Also for NADAC and SAC, and then also the federal supply schedule.
Andy, can I ask a quick question?
Yeah.
We were regulatorily required to report all of this at NDC 11 level. Is that correct? And I do wonder if this would be easier to digest if we were able to have a less aggregated version. You know, I don't know if
Yes.
that's NDC 9 or even
Yes.
something more general. Is that something
So
we've looked into?
our regulations require us to list the NDCs that are under cost review, but I don't think that we necessarily have to do all of our analysis at the NCC level. When we were developing our methodologies, this was maybe in 21 with the Hilltop team, we had looked at different methodologies to roll up NDCs. And so basically the way we went through this analysis is we literally take the list of every single NDC in existence, and then we have these different data elements. So the challenge that we run into is identifying in a scalable way which NDCs should be rolled up. So there's like a discussion of, like, for example, do you want to roll up the long acting and the short acting? That's kind of one of the examples that we had thrown out there. Or different vials versus like smart pens and stuff like that. And if you go on a drug by drug basis, it's easy enough to kind of come up with meaningful aggregations, and that we may be able to do that for cost reviews if you would like. It is kind of, again, it would be kind of a manual process, but the challenge we do is on the selection side. There's no way to just take every NDC that was ever published and have a automated way to roll everything up. If there is a way to do it, I think we're open to that from board members. I don't think there's anything in our regs that pushes us one way or the other. It's more of a methodology thing.
Yeah, I think the level of aggregation here is such that there's a lot of repetitive information from,
Yeah.
NDC to NDC, and I think we could come up with a strategy to summarize it a little better.
Yeah, I think that's a great point. I mean, one thing to consider here, so definitely, I just completely agree, and I think we would welcome any feedback that you have on this. In terms of what would be updated for a version that we post, in this way, I think one thing we can do is kind of train board members on how to use the exhibit 1 and 2 to kind of do your own aggregation rather than us republishing any of these tables, just in terms of what we can do before we post it for public comment. So I think there's a couple options there that we can discuss as a team. So I think we can come up with a way to again, use the tool. I think that's probably the quickest option. If you do want us to update these tables for the purposes of publishing for public comment, that would be a little bit more substantial exercise.
So I don't think we need to update them. I think what you've given to us is fine. I think moving forward, what I'd like to see is what Joe suggested, which is sort of average. But then what I'd like to see is the high and low NDC as well. So, are there NDCs which are much more expensive than the average or much less expensive than the average? So an average, and then the one high and the one low.
Okay. Yeah, and we can also do volume weighting. Not having our quantitative analyst on board would limit what we can do in the immediate future. But I think one thing we could also look at is, if you have big differences in NDCs, but one of them doesn't have any uses, that's something we can also provide too. Okay, great. Very helpful feedback. And we'll see what we can incorporate for the version that's published for public comment. So the next thing is information estimating the manufacturer net price and net sales of the drug. So we do use a proprietary data source and link it up to, so that's the SSR Health as well as UpToDate, which is Metaspan. And then also we link it to the our MCDB based on the methodology that we've talked about over the years. So based on this, we're able to estimate the rebate amount, and then estimate the annual WAC, and then also estimate total net spends for different payer groups. So happy to kind of answer any questions that you have on that. And then the average price concession discounts and rebates, same thing. We do a calculation compared to the MFP price. So you can just compare this MFP number as an additional metric to the WAC. So that's another analysis that we provide too. For 5.4, we go over the average price concession discount and rebates the manufacturer provided or is expected to provide under review to each PBM operating in the state as expressed as a number and percentage as identified by WAC. All of this information is in Exhibit 5, which is information received under our request for information and is confidential and proprietary. Factor 5, same thing, the information supplied by the manufacturer, if any, explaining the relationship between the price and the cost of development and the therapeutic benefit of the prescription drug product, or information that's otherwise pertinent to the manufacturer's pricing decision. Again, included in the request for information and is available to the board members. Finally, first we have Section 6, which is the therapeutic alternatives, cost comparisons, and health outcomes and research. So section 6.1 or factor 6.1 is the WAC, AWP, NADAC, SAC, and ASP and FSS, of which each therapeutic alternative has been sold. This is all included in your Exhibit 2, I believe. I want to make sure I get the right exhibit. But this is all available in the broader exhibits. So this is going to be the Exhibit 1. And this one, because it is for all therapeutic alternatives, it's just a huge file that can't be consolidated into a table for the purposes of this PDF. It is all available in the Excel document. I think if the board wants us to pick a subset of those therapeutic alternatives, that's certainly something we could do, but staff wanted to just keep it at a very high level and make sure that the board was looking at everything that they were allowed to consider at this point. Go ahead, Dr. Nokoga.
Yeah, no, I appreciate this organized way of thinking about this, because you're right, there's a lot to consider in this Section 6 in terms of inputs. I would say general comments for this section. It was really helpful to see the literature, pulling out the quantitative findings in terms of incremental costs, where they did comparative studies, what effects they found, and so on, whether it's cost or effect size or healthcare resource utilization. The context I would have liked to have before considering the literature would be what inclusion criteria or exclusion criteria were applied to identify the articles. For example, one of the sections, I think it was section 6.4, said there were 10 articles that contributed to the results that were summarized. But kind of detail on which, where did those 10 come from? What years? Was there a perspective that was imposed in terms of thinking about the study perspective? Or was it taking all comers? And I know, in the header for one of these, I think it's 6.4, that in fact it mentioned social services, not just medical and health related, I think. So, and that is a tough one for the literature, oftentimes because the way the analyses are constructed and the perspective really typically focusing on the healthcare system and not really thinking more broadly. But in fact, if there were studies that took a societal perspective or looked at socially optimal decisions, I think that would be helpful to pull out for us. I'd be curious about that, and not expecting it, but if there were studies that brought it closer in terms of geographic regions to what we're interested in, that could be something helpful to flag. I think most of the studies won't, which is fine. A lot of them really push for generalizability, so I'm not expecting Maryland specific. But if you did find that, I think that'd be important for us. But just some context on how the articles were selected. If it's a general approach, then it could be general for the whole section.
Great, thank you. Yeah, we can certainly include the criteria and the search criteria that we use in the methodology. So we will include that. So just describing that. And I would also just say this could be a great opportunity for public comment as well. So if folks, have studies that they would recommend to us that we review that don't seem to be cited in this, this is a good time for folks to add that. You can use this comment period to kind of add those kinds of things for the dossier comments. Go ahead, Dr. Anderson.
Is there a time frame for these studies? I mean, are you doing any, if something was done in 2010, do you give it the same weight as something that's done in 2024? Or, should we essentially consider that anything after, we only want to look at things after 2020 or something like that?
It's a good question. We don't set any timelines on it. It's all kind of based on when the literature is available. And I would say that for a lot of these, they kind of have landmark studies that then a lot of the modeling is based on. And a lot of those landmark studies are generally related to the approval of the drug. So that does kind of take us back to those early 2010s for some of the most substantive and important studies. But then I think we also kind of continue to pull basically as to the last date that we developed the dossier. I think that's one thing we may be able to do is kind of put a date in case we miss a study. Here's the last day we pulled and went through our process. But I think that's something that we ultimately want to leave up to the board. I think our intention is to provide the resource to you, a summary of those resources, and then each board member can kind of consider those as you see fit. But if you have recommendations, I think we're interested in any recommendations you have there.
And Andy, I have text on how we've summarized these lit polls in terms
Okay.
of different parameters down to, right, there's the date we pulled it, right? And from what database or databases. I'll
Yeah.
send that to Christine, and then if that's helpful.
Yeah. Yeah. And this is something our contractor, we work with our contractor on these dossiers. They do a lot of basically the clinical work, and this kind of can fit within that work. So it's something that I think for other cost review studies, it's going to be a different team that's doing that work, and it might have a different approach. So not a different approach, just a different documentation and a different articulation. So, but yeah, we will certainly, if you don't mind sending that to us, it sounds like there's a lot of work that we can do on this section, and we'll do as much as we can before we publish for public comment.
Yeah. Andy, I would prefer, as much real world evidence as we can, as opposed to the ones based upon just the clinical trial, because as we know, the clinical trial tends to restrict who gets in the clinical trial fairly severely. And so if you're taking other drugs, if you're over a certain age, if you have comorbidities, quite often you're not in the clinical trial. So studies that are more, real world evidence, I would put greater weight on. But, give me them all, but, just recognize that that's the ones that are important to me.
Okay. What I think what the staff can do is identify the criteria that the board would want to consider when you're weighting it. So we can pull out if it's real world evidence, and then date, to your point, is kind of that one's self-describes, but I think we can certainly try to give you the information you need so that you can weight them as you see fit. Okay. So yeah, we will spend some time on section 6 just to make sure that we have everything that the board needs for that. Going to the price concessions, discounts, and rebates, the same basically tables that were in for the reference drug. We include that information for the therapeutic alternatives, again, in that much larger exhibit 2. Yep, so you can see in exhibit 1, exhibit 1. You can see the different metrics that we were able to identify here, again, using the license data that we use to estimate those criteria. 6.3, same thing. It's in this one's going to be in exhibit 2, which is the medical claims database. This is an important exhibit to look at just because you can kind of compare across the different therapeutic alternatives and look at out-of-pocket costs. It is supposed to represent the out-of-pocket costs for insured patients, and we break it down by payer type. So this is a useful metric for the board to look at.
Andy, do we have anything on this one related to coupons or any kind of discounts that the drug companies are in fact providing to the patient, or is that just not something that we have data on?
It's something we capture as part of the request for information. And in closed session, we can talk through what we did receive. We did try to do kind of look at what's publicly available to identify budgets and numbers and things like that. And I would say that what's publicly available is not, and it doesn't let you use it in a way that you can compare it. But we did receive some information in Exhibit 5 some information in Exhibit 5 that might be useful to the board. I'm not sure if anyone else on the team wants to say
Yeah,
something.
I mean, because we've heard in the past that, although you're expected to pay $100, potentially, you get a coupon and you pay nothing or something like that. We see that in the drug ads all the time. So, I sort of recognize that. And if the drug companies or somebody can provide us additional information about that, that would be helpful.
Yeah, it was something that we asked for as part of the request for information. I do think this is probably an important discussion point for when the board starts to make their affordability determination. Again, the two ways you can decide if the drug has an affordability challenge is a high cost to the state health system or high out-of-pocket cost for patients. And we do see kind of one of the biggest talking points for lower out-of-cost to patients is those coupon programs. What's very difficult is to map you can probably see kind of gross spend on these programs. You can probably see patient numbers, but kind of mapping to the MCDB is very difficult. It's something we've looked at separate from this work. There was legislation last year on copay coupons, and when you try to find this information publicly, it's generally very difficult to get. So I think anything the board has will be probably incomplete. Go ahead, Dr. Rockower.
Yeah, the whole idea of rebates is very, very hard to get to. And at least not on these drugs, but I was involved in a number of years ago in our hospital drug committee where a manufacturer was giving an extreme discount to the hospital for a particular drug to get them to prescribe this drug for their patients so that they would continue on an outpatient basis. It was basically almost like giving it to the hospital for free, just to get people started, knowing that they'll be on it for a long time. So these kinds of things are things that manufacturers and PBM people do that we just somehow are going to have to find our way through.
Yeah, it's definitely an important topic. Any other comments or questions on 6.3?
I think I would just echo, I was looking through the Excel here and, there are over 300 NDCs for metformin. And I think we have to come up with a way to make it not be quite that aggregate. So like certain concentrations of metformin, ideally we could get grouped together and then volume weight, but we can look at some best practices for doing things like.
Yeah, no, we completely agree. I also think that might be, that's the way that our current therapeutic alternative process is set up. It's something that we can explore in terms of more refined therapeutic alternatives. I know we did receive comment letters earlier on saying that, it's probably a subset of the full list of therapeutic alternatives that is probably the most important to the board members. The way that it's currently set up is if it's the same line of therapy according to clinical guidelines, it gets included. And again, when you do have kind of your entry-level therapy being a generic that's been on the market for a long time, it's kind of a strange artifact. I'm not sure if that's going to be the case for other drugs that you review. And then again, we can help the board members manipulate the tables to roll it up in a way that's useful to them. All right, moving on to 6.4, incremental costs associated with the prescription drug product, including financial impacts to health, medical or social services that can be as quantified and compared to baseline effects to existing therapies. So I think, I'm not sure if I went over this, but this is kind of a literature review. I think Dr. Nokova's points that she made earlier all kind of apply to this. So I think we're going to go through this again and just make sure that we articulate exactly how we came up with these articles and then include some of the information that Dr. Anderson had mentioned in terms of how the factors that the board may want to consider as you wait and understand these. Any comments or questions on this? I think, as you go through the affordability review, we can flag, key findings and things like this. But for right now, I think we just want to make it available to the board for review. Okay. Section 6.5 is the information derived from health economics and outcomes research that may address the effectiveness of prescription drug products in treating the conditions for which it's prescribed or improving a patient's health, quality of life, or overall health outcomes, and the effectiveness of the drug compared to therapeutic alternatives. So again, this gets us into kind of our cost and comparative effectiveness literature. We try to summarize. So I think, again, the points that were made by board members earlier, we can take that through this section, but welcome any additional discussion that you have. And I think one thing we can also do is just look at different ways to kind of capture and basically represent the comparison of these different elements. Dr. Nukwa, go ahead.
Yeah, and thanks for this. One additional thought that occurred to me with this section, just was reminding myself that some of this is peer reviewed, some of it is gray literature. If there's a way to clarify that or group it.
Yep.
Again, there's a lot of work that's already gone into this. I know we're short-staffed, so I am appreciative of the bandwidth. But that could be something, particularly if you see that there is a particular section that has a large proportion of gray literature, maybe call that out for us so that we're aware.
Great. Yeah, we'll see what we can do there.
Yeah,
Dr. Anderson.
just following up on that, on the gray literature issue, you list three things: peer reviewed, I get that. Government entities, I get that. Nonprofit organizations is where a lot of this gray literature comes. And
Okay.
I just sort of wonder what the criteria is for the gray literature here. What organizations would you, and I don't mean specific ones, but what kinds of organizations would you say, that's acceptable and these are, we will not include? I don't need an answer right now, but I mean, I think
Yeah.
that's what we're asking for.
Great. Yeah, we can try to be responsive to that. I think the way we've approached it up to this point is we have not done kind of any weighting on that side. I think our goal is to make as much available as possible to the board members. But hearing that you want some almost not necessarily filtering, but at least flagging of different types and potential quality of the literature, I think we can try to see what we can pull together in the next week or so.
I don't want you to essentially rate the literature. This is great,
Yeah.
not so good. I just, if it is, I just peer reviewed, government, nonprofit, just
Yes.
just if you could do that. And then, I think we can take a look at whether or not we felt confidence mostly in the nonprofit sector.
Yeah.
Not saying
Okay.
it's not good. I'm just saying, we will just have to take a look.
Okay. Yeah, I think the whole team's going to go back through these sections and just kind of see if we can provide anything there. In 6.6, our statute requires I think it's a statute. Yes, our statute requires us to include the number of pharmaceutical manufacturers that produce the prescription drug product, and our finding is that Farxiga is not a generic drug product, so limited finding there. Similar issue is in 6.7. We look at the utilization and pricing of therapeutically equivalent drug products. For our analysis, we did note that according to the FDA, there are no therapeutically equivalent drug products as approved by the FDA on other applications. Yeah, I think that's all we have here. Right, so then so we have two more sections. There's section 7, which is cost sharing and insurance benefit design. So we tried to do an analysis. We spent a lot of time on this, as you can probably see from the methodology, on trying to estimate the impact of patient access resulting from the cost of the prescription drug product relevant to insurance benefit design. And basically, again, we tried to develop analysis that tried to assess the impact of, again, how much higher the out-of-pocket cost was compared to the patient use. And so it's a very robust analysis here, but I think the main takeaway is that while there are statistically significant relationships between average copays and coinsurance, and the number of prescriptions that people use in a year, any impact is small. So this was the best that we could do based on the data that we had. I think this is something where we are interested in other ways to try to understand this issue and other data sources, but just based on the claims data that we had, we tried a few different, iterations of this analysis, and ultimately found, again, can be significant, statistically significant relationship, but again, we noted that the impacts seem to be small. Yeah, I would answer any questions that you have. I would note that kind of technical discussions of methodologies or regression assumptions would be something that's a little out of my wheelhouse, and I may need to ask other staff to help. So, any questions on this?
Those were gonna be some of my questions. I guess my
Okay.
question is how best to provide the questions that we would have around, for example, these analyses, or I
Yeah.
have questions as well about the data set itself, with the 10K number.
Yeah, if you want to, I mean, you can ask them now just so we have them on the record, and then the staff can take them back. I just won't have questions. I won't have a response on probably some of the more technical questions that you have. So staff can take it back and try to address them.
Okay. I guess for me, the
Yeah,
first one would be what the variable of interest was, what analysis was done, even for the regression, to look at multicollinearity, what informed the interaction terms, how those were generated, or I guess motivated by our regulatory needs. I think just understanding the model specification itself and how that maps to our regulatory remit. That's kind of where.
Yeah, we will see if we can provide a response to that.
Okay. Yeah, just how we got to this as a final model.
Yeah.
Others that were considered.
Yep. And Dr. Anderson.
Andy, I think this is great, but if you flip down a little bit, you'll see the R-squareds.
Yeah.
And they're like, 0.01. I think it's further down.
Yeah, thank you.
You can explain 1% of the variance.
Yeah.
That's clearly not very much. So I think you could probably, with more analysis, get to 4 or 5%, but I don't expect you're going to get at a very high level just because of the analysis that you're trying to do. So, for that reason, I wouldn't put a huge amount of effort into this activity, because I don't think I'm ever going to pay a lot of attention to it, just because I don't think you'll ever get a high level of explanatory power. There's something that's always going to be missing, or just lots of variance that cannot be explained. So fine to do it, but if you want priorities, this for me would be a lower priority.
Okay, we can at least address we can provide descriptive responses to Dr. Nkoto's questions around, model design and things like that. So,
I think beginning with the factor like 7.1, what is it that we want to seek, and analytically, and again, thinking about the data limitations and so on, what's the best way to provide, even if it's an initial quantification of that relationship. It may not be regression. It may be something decidedly less complex.
Yeah, I think that's fair. And I think it's something that we are certainly open to. Again, probably for this round of cost reviews. Ultimately, what we're, in principle, the question that we're looking for is pretty, don't want to say simple, but we're trying to basically see, if the cost goes up, do patients kind of lose access? And then there's that's a great question to ask. How do you answer it? So this was kind of our kind of version 1.0 of trying to answer that based on claims data. If folks have recommendations, I think we're certainly interested in doing that in future iterations of the cost review studies. I think one other thing, just going back to Dr. Anderson's point, I think almost what you're looking for is if it's almost no findings unless there are findings, right? So to Dr. Anderson's point, for most drugs, it's probably going to be a very nominal impact just based on this style of analysis and what's available here. But if we did find the if we did have a strong finding there, then it would be something that would be important to you. So, yeah. But again, I think this is something kind of going back to, go ahead.
No, please go ahead.
I was just going to say, some of the, so this is, I would compare this to, I mean, slightly different issues, but like impact of the drug on state budgets, where the principle of the element is clear, but the actual analysis is pretty sophisticated with a lot of different options. I think we are going to continue to refine these kinds of things over time, and definitely welcome recommendations on how to do that.
Yeah, no, I absolutely agree with this point you made, because as I look at factor 7.1, that is not an easy question to operationalize.
Yeah. Sounds good on paper, though.
I'd be curious what's in the literature about this.
Yeah.
Has anyone generated an effect size for that
Yeah.
relationship? And that may be where we start to first then get a sense of what would it take to do this analytically? Do we have the right data sets and measures, et cetera?
Okay. Yeah, we can certainly do that. Let's take it back and see if we can do a cursory lit review. Go ahead, Dr. Anderson.
So, I get that this is based upon historical data and what the PBMs and everybody have done in the past. But, if we do make a significant change, we have to anticipate how PBMs and other parts of the industry are going to respond, and whether or not other companies respond by changing their price. So there's a whole series of factors that essentially, looking at historical data, you cannot always tell. So
Yeah.
I think it's important to do it, but I think for me, as I said, it's less critical because I expect other changes to occur.
Great. Yeah, and I think one last thing to say on this is, the first two drugs that you'll be looking at, first two dossiers are pretty mature drugs that, generally do have strong coverage. So I know ultimately the board needs to make the determination on if the out-of-pocket costs are high, but this is one where it's, again, a pretty mature market with pretty strong coverage. And that might just be kind of the finding that you see in 7.1. Okay. Okay, so our team recorded the different questions that you have. So I think we can provide responses. Then the lit review is something we can do internally pretty quickly. Just to see if there's literature out there that addresses it. We did kind of at a high level when we were first doing the methodology development explore, but I'm not sure we've done it in detail for each drug yet. So we can take a look at that. Next up is, this is actually, I guess we started to discuss this earlier, the current or expected dollar value of drug-specific patient access programs that are supported by a manufacturer or the manufacturer for the drug product under review and the policies surrounding that implementation. So for this, we went to different publicly available sources and tried to identify the terms of use for the different patient assistance programs. We identified a few different patient assistance programs. What we were not able to do is the expected dollar value. We have the specific, like for each script, we have it. But again, it just shows out-of-pocket costs when you go through the program. It doesn't kind of put the dollar value on that. So that's something that this is what we were able to find based on the publicly available information with the limitations that we talked about earlier. Any comments or questions on this?
Yeah, I don't think you'll be able to do anything more than that.
Okay. That's good. Average patient copay and other cost sharing for prescription drugs in the state. So we did provide a table for the different payer types. And again, you can kind of see, the different ranges of the out-of-pocket costs and copays. There are different flags for each of the different types, so we were able to kind of stratify by those different flags. But this is a good kind of overview of the copays and other out-of-pocket costs. Any comments or questions here? Okay. 7.4, there's the cost share. So this includes the different cost share for different types of payers, and this goes kind of into that percentage amount. The table doesn't include Medicaid because we don't have out-of-pocket costs due to their standard copay structure. So the cost share is the patient total out-of-pocket cost divided by gross spending, which yields a percentage of the gross spend paid for by the patient. Again, just noting that this is a statutorily required metric. So we did spend a lot of time just working on exactly what this definition was supposed to represent. We also include the mean, median, and 90th percentile for out-of-pocket costs compared to state incomes. So we include the median household income and the mean household income in 2023, and then compare that to different 23 data. So we welcome the board kind of walking through that. Let us know if there's any different things you want us to, kind of parse in that analysis. Okay. 7.6, an assessment of the impact of the prescription drugs costs to access by priority populations and the impact on equity. So we spent a lot of time on this analysis. The claims data doesn't include demographic information for the vast majority of patients, so we were unable to make it a conclusive assessment. We have kind of a number of different strategies that we tried, so we can articulate that if that's a useful thing to share, just like what we tried when we were trying to address this data element. Based on the discussion with the board when we were developing our regulations, we did state that this is an extremely important data element to try to consider and work through. So if demographic information was available, we were anticipating on using a linear regression technique to assess whether there's statistically different differences in spending and utilization between identified priority populations. So again, there were no definitive or substantial findings on that analysis, again, just based on lack of demographic data. This is one, as with a few of these different elements, where we'll continue to play with different methodologies and data sources. If anyone has anything that you want us to try to do before we publish this is for public comment, I think we welcome that kind of feedback. But otherwise, I think this is one we'll just continue to try to refine the methodology over time to try to find meaningful results.
So the Medicare claims data does have self-reported race information, for example.
Okay.
So you could, using claims data, analyze at least race in the Medicare population.
Okay. Okay. We'll take a look at that. And then Dr. Nukwe.
Yeah, and I think what would be helpful for looking ahead and think about process would be maybe the staff could do a review of recent literature to see who studied this question and what methodology did they use, not necessarily the conclusion, but the methodology, because the difficulty with, had you had race and ethnicity information and you found a negative correlation with spending, how you interpret that versus a positive correlation with spending could have very different implications for what access meant. If you didn't have access and you're spending less, if you didn't have access and you're now spending more because you're waiting till you're more severe to access a healthcare system. So this is also tricky, which is why I'm curious if we could at least summarize, based on reviewing more recent papers or key papers on this topic, a general methodology that could then inform future cost reviews as to whether it's feasible to do it with NCDB data.
Okay. Yeah, and I think one thing we talked about when we were first developing the regulations is also ideas on how to do this without MCDB data. Are there other methodologies we can use? It's something we weren't able to do for this round of cost review studies, but certainly I think it's something we can discuss for future phases of the cost review study, different data sources and tools and stuff that we can use.
Yeah, I totally agree with the Barry that, there's many factors why people spend more or less, which is part of the reason why I suggested Medicare, because then you have a fairly standard benefit package. does vary from managed care to, or Medicare Advantage to fee for service Medicare, but it's pretty standard. So you would expect similar of access. Again, lots of other factors could be involved, but it's probably the best to take a look at that issue.
Okay. Yeah, we'll see if there's anything we can do there. All right, just a couple more factors, and then we'll move on to the Exhibit 5. So next, cost of the health plans based on patient access consistent with the FDA label. So this, we projected commercial spending. So that's available to the board members. In Factor 8, so this is all of the other information. So we had a number of different elements that we're able to put in here. Primarily, looks like about 4 factors. First is public input. So as we've mentioned, we do have a number of different opportunities for written comment requests. So we were able to put all of those into an aggregated package that the board is able to review. So we do that'll all be available to the board for their consideration. Next, we have a factor analysis of the impact of state and local federal regulatory and compliance issues related to the prescription drug product. Staff kind of explored this issue, but did not identify any other regulatory or compliance issues that would provide additional context for the market related to this prescription drug product. Again, kind of general lit review. And then the last 2 items, 8.3, input from state and local governmental entities and the entities contractors such as health plans and health administrators. So the staff has been kind of working to reach out to state and local government partners. But up to this point, we've only made the public comment process available to them and have not received any public comments. I think in the future, as we identify partners that may want to work through the different elements of the policy review process, we will make sure that we are working to get direct input from the different state and local government partners. So I think, again, just with the first round of cost reviews, I think the input is limited up to this point, but something that we are going to continue to try to build moving forward.
And Andy, can they do that on a confidential basis as well as a public basis, or are they required to do everything on a public forum? Or do you know?
It's a good question. I think things that they would want the board to officially consider, I'll have to take that back. I guess there's no reason they couldn't do some sort of submission for confidential proprietary information, because we do have a process for folks to do that through public comment. But up to this point, they haven't submitted public comments through that process.
But maybe the reason is because they want to send something privately. So I think it's important to tell them that that is an option if they choose to do it.
I think that's right. And I think we'll have a more structured process for future cost reviews, just making it very clear, here's what would be helpful to the board, and feel free, and here's, feel free to submit information if you're interested. Yeah. Also, again, as we do have a more kind of concrete partnership with different entities, they'll probably want to start to weigh in a little bit earlier in the process. All right, and then the final element is information analyses submitted by an entity under 04 of this chapter. So again, oops. Yeah, so this is basically just making sure that we encapsulate everything that's collected through the RFI. So that's all available under Exhibit 5. So this is the dossier. Here's the table of exhibits. So as we'd mentioned, this again was just to kind of walk you through what we think the final format would look like. I think we got some really good comments and some minor adjustments that we can make before we publish this version for public comment. Then we are going to post for public comment, hopefully by the end of next week at the latest, for both Farxiga and Jardiance. When it's posted, we will set the timeline as well as send a blast out to all interested parties. And then all of that information will be available to the board for you then to take action in a future meeting. So I think that's the general kind of timeline that we're working on for these two. I think we're also, I think one of the big things to note is, obviously we're pretty late in the year on getting these dossiers out. It's something we've been working on, as since basically November of last year, we've been trying to get this dossier together. And I think staff now knows the time that it takes to put these dossiers together. And I think we can put together realistic timelines for each of these moving forward. So we have we know how many FTEs it takes for each of these. There was a lot of front end work just in terms of, you'll notice that we kind of reorganized everything into different elements that had similar themes. So a lot of just that organizational process and cross-referencing to make sure that everything was available to the board. That took a lot of time and effort, but now that that template's in place, I think we'll be moving forward pretty quickly. So with that, any other public comments that the board wants to discuss based on the dossier that was presented?
Just to commend you and the staff on standing up this first one. I think that's oftentimes the hardest. And I did see the organization with the different factors. It made it easier to sort of group them and think about them together before moving on to other sections. So just commending you all on the work to date. It's fantastic.
Great. We hope the first one's the hardest, so we'll see.
Hey, Andy, I have a question. Just going back to 8.3.
Yep.
Who are some of the folks that you think might contact us in regards to that?
Yeah. So
Is it MHBE, HSCRC, MACC, people like that, or are you thinking more of?
I think it's all on the
local
table.
county government?
Yeah, so I think we want to have a working relationship with all state and local government entities. So the folks that you mentioned, MHBE, HSCRC, MHCC, they'll have probably good analytical input to actually be able to kind of talk about some of the findings in here. But I think what we are also particularly interested in is some of the state and local government payers and their feedback of like, this is a drug of concern. Here are our general findings. They may be able to share things like their net cost and things like that. But a lot of that is just kind of getting those relationships built. So I think that, once that is up and running, I do expect a lot more kind of interaction with those groups.
Okay. Thanks.
Yep. All right, so I think this is the end of the public part of the meeting. We do have Exhibit 5, Exhibit 5 items that we would like to present to the board as well. So, Mr. Chair, if you wanted to take us into closed session, I think we can also just reiterate that we don't plan for the board to take action after this. So if folks have other things to do, they don't need to wait for us to come out.
Right, they don't need. It'll be an adjournment after closed session. There won't be any other business that I know of after closed session. So with that, unless any other board member has any other comment in regards to cost review study, staff's presentation. If not, I'll consider a motion to go into closed session to discuss confidentiality, trade secret proprietary information under GP 3-305B 13 and HG 21-2C03E 14 Farsiga, and to consult with counsel and receive legal advice regarding the cost review study under GP 3-305B 7. Is there a motion?
So moved.
Moved
Second.
by Jerry. Second, Barry, was that you?
No, Steve.
Oh, Steve, sorry. All those in favor? Aye.
Aye.
I
We will go into closed session. Christina, are you driving?
Yeah, so I'm about to open a room for you all.
Yep.
Andy, since you're the host, you might not get an invite, but you can automatically see the room under breakout rooms. I can come over and help you if there's trouble, but
Okay.
are you ready for me to open the room?
Yes.
Okay,
Yes, please.
I'm putting you in right now.
Okay. So how does this
Okay, everyone back? Board?
Yes.
Yes.
All right, I have 4:45. I'll entertain a motion for adjournment.
So moved.
Second,
Second?
all those in favor, aye.
Aye.
Thank you very much. Until next time, we will stand adjourned. Thanks, Christina, staff, everyone.
Well.